Gynecomastia is male pattern breast growth. There are various reasons for it. In fact, in men over 55, it's much more likely you'll have some gynecomastia than not. It's almost normal age-related change. So the commonest cause would be no cause at all, really, just what we call idiopathic. And after that, there are other reasons, like commonest reason being medication provided by your doctor, can sometimes stimulate male pattern breast growth. In younger men in the teenage years, again, it's much more likely you'll have gynecomastia under the age of 18 than not, but less than 5% of men are left with any gynecomastia after the age of 18, 19, and that's called persistent pubertal gynecomastia as opposed to age-related gynecomastia. So it can happen on one side or both sides, and the main symptom, as you might imagine, the main symptom is actually pain and tenderness beneath the nipple in a man. Gynecomastia tends to be very tender as it grows in the growth phase, as we call it. And obviously the appearance of a lump behind the nipple, a rubbery lump, but right behind the nipple. And, you know, in bad cases, severe cases, you can actually get some breast growth with skin redundancy with a proper breast. So it's anything from a tender lump behind the nipple through to full breast growth, really, can present as gynecomastia. Surgery for gynecomastia is a complex issue because what you don't want to do is basically replace a minor cosmetic abnormality caused by the disease with a more major cosmetic abnormality caused by the surgery to treat that disease. Now, the vast majority of gynecomastia we see is just a painful lump behind the nipple with very little excess skin and little aesthetic issue, but nonetheless, a prominent nipple with pain is not a very pleasant thing to have. In the early stages, you may well get away with treating it with anti-hormonal medication, which can be provided by a specialist to try and dampen down the estrogen once the blood tests have been done to make sure there's no other underlying medical cause. So once you've established there's no underlying medical cause, course of anti-estrogen therapy can sometimes stop the gynecomastia in its tracks, and that's as far as you need to go, which is actually a good outcome. However, in some cases, this small lump behind the nipple does not respond to the anti-hormonal medication, and then you have to consider surgery. And this is when the discussion has to start. Now, traditionally, the surgery for gynecomastia has involved an incision around the nipple, or around the areola, as we call it. And then you remove the underlying lump or breast tissue underneath and then stitch back. Now, that's the traditional operation, but the problem with that is, particularly in men without particularly hairy chests, is you tend to get this big scar around the nipple, and it looks a bit like a target. Now, it does fade with time, but nonetheless, it's clearly a badge that you've had surgery on your breast, which for men is not always a good thing. So what I developed about 20 years ago was a procedure where I can remove this lump behind the nipple using a remote probe that's put in through the axilla, through the armpit. So the only scarring that's visible is a 4mm scar hidden in the hairline of the axilla. So there's no visible evidence on the front of the chest that any gynecomastia surgery has actually taken place. This avoids the scarring, and the other problem that men tend to get is hypertrophic or raised and red scarring. It doesn't cause any problems with that because clearly there's no actual scar on the nipple itself. And if you combine that with liposuction, and it's a very mild case of gynecomastia, then you avoid any visible evidence of surgery, which clearly in groups such as bodybuilders or actors, etc., is a good thing because it can affect their careers. And in general for the population, clearly, if you don't have to have a scar, why have one? So that's an operation I perform. For more serious cases where you've got skin redundancy, then you'll need to have the periareolar approach, where a donut of skin is removed around the nipple at the time of the surgery. The nipple is then raised and the underlying breast tissue is removed, and then a purse string suture is put into the external external diameter of the donut and pulled in to reduce the skin envelope and thus tighten the skin around the nipple, and obviously reduce the areola at the same time if necessary. But that does lead to the scar around the periareolar scar around the nipple that we try to avoid now in the lower grade cases without the skin redundancy. So there's your two approaches. The remote probe approach avoids scarring around the nipple. For those patients with significant skin redundancy, then what's called a periareolar approach with a donut of skin being removed is the optimal approach. With minimally invasive excision, the answer in many respects is in the title. What we do is we use a very small incision, about 4 millimeters or so in the armpit. And then I use a probe called a vacuum-assisted biopsy device, which is a large diameter cutting probe that goes in under the skin and behind the lump under the nipple, and then sequentially removes the glandular tissue with a cutting device. It doesn't have to keep on being put back in and out like a normal core biopsy device, because what happens is when it cuts the gland, that cylinder of tissue is sucked back down the probe into a little basket. So each time you cut the gland, this tissue comes back, and you may have to do 100, 150 type excisions, because obviously it's only a small bit of tissue removed each time. That all happens during one operation, incidentally. You don't have to keep coming back 150 times. It takes about an hour to do, but the advantage is there is no visible scarring on the chest wall. There is nothing there. You know, the worst outcome is, well, there is no worse outcome, because effectively the glandular tissue is removed without scarring. So you may have some skin redundancy because we're not removing the skin, but again, that would be about patient choice and patient selection to try and avoid trying this procedure in a patient with a lot of redundant skin, because it won't work. I'll give you some idea of the spectrum of people this can be used on. I also do a lot of transgender surgery, so female to male transgender surgery, and for clients with very small breasts, I use this technique in that patient group as well, with great success in terms of achieving their outcome without giving them any visible scarring. So it's a very adaptable technique, but it's about having the experience to select the patient appropriately and not try and do the operation and give the patient too much expectation if clearly the redundant skin is not going to make it possible when we'd be looking at a periareolar type operation. The difference is you have no visible scarring on the chest. So therefore, you have two small 4 millimeter incisions if you've got bilateral disease in your armpits, and that is all the evidence that you've ever had any surgery to your chest. So it allows you to function normally without people looking at your chest saying, what are those scars, etc., etc. You know, it's a game changer in terms of outcome, because you don't have those visible scars around your nipple, which in a man is clearly a badge that they've had surgery to their chest. We've done some follow-up studies on, we published 2 papers on this looking at patient satisfaction, and the satisfaction was rated as good or better in 85% of cases. So it's not 100%, you know, as I said, never trust a surgeon who says he's perfect, because he's either not done enough or he's lying. But 85% of my clients say the outcome is either good or better from the minimally invasive surgery. Recovery from minimally invasive surgery, because we add liposuction in as well, you do look like you've been in a bit of a fight, because the bruising is quite extensive, generally down from the clavicles, the collarbones, all the way down, halfway down nearly to the umbilicus. So you will look very bruised, and you'll be uncomfortable, but normally you're out of hospital the next day. The bruising can take a few weeks to settle, but in terms of activity, you're driving after about 10 days or so, sometimes less, returning to work after a couple of weeks. You do have to wear a compression garment for a couple of weeks at least, normally a tight one for a couple of weeks, and then I like people to wear one a bit longer to try and shape the chest, allow the skin to re-drape on the chest wall for about another 4 to 6 weeks after that. But in terms of activity, back to the gym after a couple of weeks, you know, relatively normal behavior after a couple of weeks, because again, unlike the periareolar type operation, the round block round the nipple type operation, the scarring is so small, it's not a problem. The healing is very quick because you're dealing with a 4 millimeter scar rather than a scar all the way around the nipple. So recovery is actually very quick.